I want to welcome everyone to Hawthorn University's award-winning Holistic Health and Nutrition webinar series, and thank you for attending today's presentation with Dr. Katherine Alexander Anderson, presenting on Explaining the Unexplained, an integrative approach to unexplained infertility. You know, I'm certain we're going to receive terrific information here from Dr. Katherine, so this presentation is being recorded and it'll be available for replay on our website in just a few days. And we'll certainly have time for your questions at the end of this presentation, so I'm encouraging you to write your questions or your comments in the webinar question panel at any time. I'm your host, Paula Bartholomew, one of the founders of Hawthorn, and I'm delighted to get us started. Dr. Katherine joins us to discuss unexplained infertility, which may affect up to 30% of couples worldwide, yet the diagnosis and treatment and management of these cases are often ill-defined, inconsistent, and erroneous. A true diagnosis of unexplained infertility requires a skillful clinician and sufficient diagnostic testing. Lack of standardized diagnostic protocols lead to non-identification of explainable cause and therefore improper treatment and loss of time. Western medical treatment approaches typically involve drugs, procedures, and surgery as a way of dictating the reproductive system. But there's many reasons that exist for why the body is not conceiving, even though it's not showing up diagnostically. And in her presentation today, Dr. Katherine will explore what unexplained infertility is and isn't, how to question the status quo when a patient has been labeled with this diagnosis, as well as how to assess and address this condition with an integrative mindset. And after the lecture, attendees should be able to recognize a client with fertility problems, assess the client correctly, be able to determine the contributing factors, and able to initiate the appropriate workup and prepare a reasonable functional nutrition program for clients with unexplained fertility. I do want to encourage you, though, to be mindful of your scope of practices and refer to a qualified medical professional for diagnosis whenever appropriate. You know, it's such an honor and privilege for me to have Dr. Katherine with us and for me to be able to introduce you. She is a doctor of acupuncture and Chinese medicine, international speaker, and president emeritus of the American Board of Oriental Reproductive Medicine, ABORM. She currently holds the position of executive director, and they are leading the organization to ensure fertility patients worldwide receive the care from the most knowledgeable and highly skilled practitioners. Dr. Katherine has over 25 years experience in healthcare and understands an integrative approach to health. Her private practice is dedicated exclusively to reproductive issues and women's health, and she has busy clinics in both Maine and New Hampshire. In addition to leading ABORM for the past 3 years and running her clinics, Katherine is currently completing her PhD in Chinese medicine gynecology. Her doctoral thesis is a study of the clinical efficacy of the menstrual cycle regulation on infertility and time to conception. You can connect with her at her clinic at rhythmsforwomen.com and on her Instagram, which is The Fertile Truth. All that said, it's really a pleasure to have you with us, Dr. Katherine. So thank you for being here.
Oh, thank you so much, Paula. Yeah, it's great to be here. I mean, I've had an exhausting day of treating patients, but I get my last chi for the day, and I'll give it to you folks before I drive home. So
fantastic. Well, I'm really eager to learn more from your expertise that'll truly support us to understand and be able to implement this information. So thank you again.
Yeah, you're welcome.
All right, I'm going to turn it over to you if you're ready to go.
I'm ready.
All right.
So it's great to be here and talk about infertility and my research into specifically unexplained infertility really grew out of my clinical practice, in which patients would, continually come in with this diagnosis, and then after I started exploring more, I would find that it wasn't really unexplained at all. Just recently, new patient came in yesterday, had been seeing another practitioner for 1.5 years, said, yes, we have this diagnosis of unexplained infertility. Before she came in, I had said, we really need to get a sperm analysis from your husband. She comes to her initial appointment with this, come to find out it's not unexplained at all. Low sperm count, low motility, low morphology. So yeah, just finding out what's going on, because something is going on. So what I'm going to share with you today are some things that I've learned along the way, practicing, and regardless of what type of clinician you might be, hopefully you'll be more informed. And as Paula had said, just being mindful of staying in your lane, whatever your discipline is. But sometimes, it's really important just to know when to refer out. So, I like to think of unexplained infertility. I say, look, is it really unexplained? Or is it unidentified? Just like flying objects, right? Unidentified flying objects. There are these things in the sky. There's a plane, a star, a meteorite, whatever it is that we can see in the sky. We know that they exist, but we don't really know quite what they are, just like unexplained infertility. We can see that something is happening because the patient's not conceiving, but we can't really explain what or why sometimes with the lens that we're looking at. So it doesn't mean that it's not real. It just means that we haven't identified it yet. So looking in general at the causes of infertility. Now this information comes from United States IVF data. This one is from 2014. It's pretty similar year over year. But really in the US, there's no good system to log infertility statistics. Currently doing my PhD in China, and I did a retrospective study. And they just assumed that I could go into any hospital here in the US and just gather all of this information. Unfortunately, it's not that easy here like it is there. So based on what we know, we might lump people with unexplained infertility. Can you see my cursor? If
yes.
You can.
Yeah. Okay,
great. This unknown infertility, unexplained, about 14%. It depends on who you ask, essentially. So when you look at couples, again, about 10% of couples may have unexplained infertility. These statistics could be overinflated, underinflated. Again, it's a bit contradictory, but we know that it's significant enough that it's actually an issue. Again, when we're looking at just the female, we can't really diagnose unexplained infertility by just looking at the man or the woman, and we'll get to that definition in a minute. But, again, we could probably say about 10% of the females that are having fertility issues will be unexplained. A lot of you, if you've done any fertility work already, you might know ovulatory issues really are one of the top reasons that women are having difficulty conceiving. And many things that we can do for that. That's another whole talk, of course. But the American Society of Reproductive Medicine, they say that with unexplained infertility, they say, it could be even higher than that. So when we're looking at the male, this is interesting, right? So there's certain things like, we have these primary gonadal issues, which could be typical infertility issues, like maybe there's sperm issues, erectile dysfunction, things of this nature. But this statistic comes from the Clinical Gynecological Endocrinology and Infertility from Speroff and Fritz. I don't know if anybody knows this classic textbook. It's really quite dense, full of information, but it's a good resource for any clinician that's interested in infertility. But they say that unexplained infertility in the male now, and they're calling it idiopathic infertility, and we're going to break that down in just a minute, because idiopathic infertility is different than unexplained infertility. But they're saying, hey, in men, idiopathic infertility could be up to 45%. So again, back to the patient that just came in, she could have been treated with Chinese medicine for the next 5 years and probably never get pregnant if we didn't address the issues going on with the man. So really, really important to know what you can do and what you potentially can't do. And you need to have all of the information. So what really is unexplained infertility? Well, if a couple's really having difficulty conceiving, it's been at least 12 months of regular sex, and they haven't really identified any abnormalities. We'll talk about what they look at. It could be 10, 15, up to 30%. sometimes, again, these definitions depend on who you're really asking. So unpacking that a little bit more, we're really looking at couples in which they've had a routine semen analysis, and that's within normal ranges. We'll talk about what normal range might be. And that we've ruled out that there's really anything that we can find with the woman. But, I ask the question, is it unexplained or just undiagnosed? I think that undiagnosed is really what we're talking about here. And, at this stage of the game, Western medicine's been around for 100 years, where we've really started to get a lot of diagnostic information. But I think the fact that we believe that there's so much unexplained infertility right now is really just because we just don't, based on the current limitations of what our science really can do right now, we just don't have some of these tools. So really, unexplained infertility is this diagnosis of exclusion. So we've done maybe an HSG and a hysterosalpingogram, and we've seen that the tubes are open, the fallopian tubes are open. A woman is ovulating regularly, right? And we've done a sperm analysis, and we've said that the sperm analysis is normal. And really, the doctors look at this and they say, okay, let's do at least 2 sperm analyses so that we can at least make sure that the first one wasn't a fluke for some reason. But essentially, they're doing this normal, they're doing a normal sexual history, physical exam. They want to make sure that the structural issues are working properly with both the men and the woman, the man and the woman, excuse me. So what about this issue of unexplained versus idiopathic? I have Western medical doctors still confuse this. I think a lot of people confuse this. But idiopathic is different. Unexplained is we don't have a cause. But when we're talking about idiopathic infertility, we're really saying we know there's a cause, but we don't know the cause of the cause. So 2 good examples of that. One, the male. If a male's sperm analysis comes back abnormal in any way, but we can't really figure out why it's abnormal, that's not really unexplained. That's idiopathic. A female, if a female that's, let's say 28 years old, and she's diagnosed with a low AMH, anti-Müllerian hormone, which is essentially, for those of you that may or may not know, is oftentimes used to judge a woman's egg reserve. So in a young, healthy woman, her AMH should not be low. But if she's diagnosed with a low AMH and she's, not over 35 or 40, that might be considered more idiopathic. So does it really matter? Yeah, I think it does really matter. And there are plenty of examples in my clinic where a patient comes in with this diagnosis of unexplained infertility, and we start to explore a little bit more, and we find out that really it's idiopathic, and there's some things that we can do to address that. So this pretty much says the same thing here, just again, but what's interesting is, if you look at the idiopathic, is there could be the percentage of the cases that could be idiopathic is quite high. So it tells me that that there's some things going on that we don't really know the fine details of, but we know there's something. So what that tells me in my clinic is that I need to keep looking. So we're going to talk a little bit about unexplained infertility in the male and then the female. I intentionally, when I talk about this subject, I intentionally like to talk about the male first, because the male's oftentimes just considered secondary to this whole issue of infertility in the first place. And we know that statistics tell us that oftentimes with fertility that the man can be the problem or contributing problem to fertility issues up to 50% of the time. So that's pretty significant. And if one thing you get from this lecture this evening is it's not all about the woman. So, I am always trying to get more of the men into my clinic And sometimes it's hard. And it's especially hard when a reproductive doctor tells the man, oh, your sperm analysis is fine, don't worry about it. Well, a sperm analysis isn't really a fertility test. It's just one marker that we look at. So just, I've seen men with a normal sperm analysis not conceive, and I've seen men with an abnormal sperm analysis conceive. So that should not be the end all. So again, we've talked about this, unexplained infertility in men can 10%, up to 45% if we're talking about, really this idiopathic infertility. And again, with men, usually, when we're talking about idiopathic, we're talking about, there's something not right with the sperm. We can see that, but we haven't really looked deeply enough to figure out what that is yet. And so I ask the question, is the man more important? And oftentimes, I'll answer yes to that. I think that, it can't be forgotten. So this is interesting. World Health Organization, had sperm guidelines. They changed those in 2010. And what they essentially did, they did a study. And you'll see the study. They looked at 1,900 fathers. They had been trying to conceive for a certain amount of time, and they looked at their sperm parameters, and they looked at different countries, and they decided to lower the reference ranges for sperm guidelines. So again, we know that sperm analysis alone is not a good predictor of fertility because it doesn't test for sperm dysfunction. Right? There's certain things that could be happening with sperm that we can't see on a sperm analysis. Maybe there's some DNA damage, some oxidative stress, some antioxidant depletion. So, I think that's important to keep in mind. But these guidelines were also pretty controversial because some people criticized this study, saying that it didn't really address the semen analysis globally, didn't address certain races and regions, despite the fact that people argued that there were some methodology issues with this particular study. But I think one of the really striking things for me about them lowering these reference ranges is now they're including more men in these normal ranges. So, if before, fewer men were considered normal, you might look more deeply to see, okay, what's going on. But the other important thing in this is that what they did in this study was they used the wrong population. They looked at the semen analysis from a fertile population, when really, I think, they should be looking at infertile men and looking at their sperm to see if there's anything that they can uncover there. So, when we look at possible causes of unexplained infertility in men, so these are some of the things that I start considering. And I mean, each of these are very complex, and we're just going to touch on them briefly. But some of the things that I might consider are there immunology issues, right? So anti-sperm antibodies can be common when there's low sperm motility, but they can even be present with a normal semen analysis. If there's a history of infection or inflammation or vasectomy, then there can be anti-sperm antibodies. In Chinese medicine, we see this manifesting as oftentimes damp heat or qi and blood stagnation. So, what's interesting is there's an infertility expert, doctor out of New York, and he says that the diagnosis of immunological infertility should be suspected in all cases of unexplained male infertility. I had a doc the other day telling me, like, oh yeah, we don't even do that anymore. I couldn't get to the root of why, but they think it's unimportant. Dr. Chapman here, he thinks that up to 40% can be involved in any kind of immunological issues with unexplained infertility. So There can also be some genetic issues going on, right? So they've, American Society of Reproductive Medicine, you know, they have a study, they're saying like, look, 8% of unexplained male infertility, men, they have DNA damage. And, you know, this can be from a number of things: heat, tobacco, alcohol, radiation, you know, a lot of environmental factors now. And, you know, when there's any kind of DNA fragmentation, you know, it might result in poor fertilization, but oftentimes it results in higher miscarriage rates. So certain medications as well can affect some of this stuff. So again, you know, 80% of sperm dysfunction can be due to this high sperm DNA damage. So this is becoming more and more prevalent. And again, my last bullet point here is, I think the takeaway is that, you know, oxidative stress can impair this whole process of sperm development. And the sperm may still be able to fertilize the egg. And that's where, you know, a pregnancy might happen, but the miscarriage rates might be higher. We can't just look at that and say, oh, right, that's just because of the woman. So I just want to touch a little bit on this idea of oxidative stress, and unexplained male infertility applies to female infertility as well. There seems to be, I have another presentation that I do on supplements in infertility care, and the title is, you know, are we hurting or causing more harm? I think the world's gone a little cuckoo with this over supplementation that we have right now. I think, you know, oftentimes patients come into my clinic and they're on, you know, dozens of supplements, 6, 12, and they're spending a lot of money first off. But sometimes one of the first things I do, you know, patient comes in and says, oh yeah, I'm trying to get pregnant, I'm on all these supplements. And I say, really, how long have you been trying to get pregnant? Oh, 2 years. How long have you been on all these supplements? Oh, 1.5 years, 2 years. Well, they're not really working, are they? I have plenty of examples of supplements actually interfering with fertility issues. Ovulation, a big one. You know, we need a certain amount of inflammation in the body for proper ovulation to occur. So if somebody doesn't have a lot of inflammation and they're taking a lot of anti-inflammatory supplements, we might be doing more harm than good. But the whole idea here is just to get you to stop and think about, you know, is there truly oxidative stress going on in the body, right? Like, there should be a balance of oxidative stress. We need a certain amount of oxidative stress, and we don't need too much. So just pumping a patient full of antioxidants, exogenous antioxidants, foods I think are a little bit different. But I just think that it can overwhelm the body's natural response to managing this. So again, we know that bottom line here is that, you know, oxidative stress is a factor in unexplained male infertility, can affect the sperm, excuse me, and, you know, there's certain oxidative responses that need to happen. They're the body's primary defense mechanisms against this. So you know, there are tests that you can do to you know, check one's oxidative levels. But really, you know, I think the question is, does this mean that we add more supplements? And, you know, my personal choice oftentimes is, you know, I supplement in moderation and only when necessary. And I use the other tools available to me, specifically, you know, lifestyle and diet and acupuncture and Chinese herbs, but things that are much more customized to the patient in front of me. So with the environmental factors, you know, I think this is, you know, a huge part of what's going on out there these days, is that there is a lot of environmental stress. The radio frequency waves here can create, you know, harmful chemicals in our body. The cell phone radiation can decrease your melatonin levels. Melatonin, you know, is not just a sleep hormone. It's also an antioxidant. So a lot of people don't think about that. So, you know, if someone's taking melatonin every night because they're trying to impact their sleep and they don't have a lot of inflammation in their body, maybe they're doing themselves more harm. So the obvious things, right? You know, I always tell my patients, look, the men, no cell phones in the front pocket, no laptops on their lap. And, you know, there's a bit of controversy as to, you know, whether sperm concentrations have decreased over the years. Some people are saying yes, some people are saying no. But, you know, I think that the concentrations probably have decreased. And there's some research out there to support that. So medications, as well, you know, oftentimes I have young men, you know, in their 30s come into my clinic and they're on statins. And that is one of the worst things for your testosterone. And, you know, the family practitioners are usually the ones prescribing this, and the patients say, oh, is that fine for my fertility? And they say, yeah, don't worry about it. And, you know, there is a fair amount of research out there as well that, you know, 95% of the people on statins don't need to be on them. And they're quite a dangerous little drug with all kinds of side effects. So I'm not a Western doctor. I cannot, you know, recommend to a patient to start a certain medication or discontinue a certain medication. But I can share my thoughts on that. And once patients become more informed, then they talk to their doctor, and 9 out of 10 times, every time that's happened, the doctor will take them off it because they didn't really need to be on it in the first place. So that's something that I ask and consider. Steroids, you know, we know steroids can decrease sperm production as well. The antidepressants, anti-anxiety can have some effect, also affect libido. And, you know, marijuana is a big one now. It's legalized here in Maine, and it, you know, it's amazing that how many patients are smoking it a lot. And it sounds fairly obvious, but I have patients that even ask me, really, is that really bad for my fertility? And the answer is, yeah, absolutely. There's again fair amount of research on that, and vaping is no better in my opinion. That's just chemicals. Yeah, just good questions to ask. And reflux meds as well can definitely affect, you know, your male hormones. And yeah, again, I have a lot of people. I've got, you know, some few tricks to help people get off of these types of medications. So, you know, oftentimes there are some nutritional deficiencies. And again, you know, I always try to work from a nutritional standpoint first. You know, nutrition and diet is one of the basic tenets of traditional Chinese medicine. So if somebody has low vitamin C, that can be impacting the DNA. Vitamin E can help to protect the sperm as well. Low CoQ10 levels. CoQ10 is a naturally occurring enzyme in the body. It's not just a supplement, but if there's decreased coenzyme Q10 concentrations, it can affect the sperm motility and the count of the sperm as well. We've kind of talked about DNA fragmentation a little bit, but it's interesting to see that, again, you know, if the sperm has some DNA fragmentation, you know, I'll just keep driving this point home, is the sperm analysis could be normal, the sperm could still be fragmented, the sperm could still be able to fertilize the egg, but the miscarriage rate might be higher. And especially if the man is over 40 and there's some DNA fragmentation, the sperm, the miscarriage rate could be higher as well. And so that old, you know, like, oh, don't worry about it. We just worry about the woman. We don't worry about the man and, you know, how old he is. Well, you know, I do think that the age does matter. So the question is, you know, is the sperm analysis enough? If you've been listening to what I've been saying, then you probably, you know, hear me say like, no, sperm analysis is not enough. And, you know, we know, like, what, on average, almost up to 30% of the time, men have this normal semen analysis and they're still not able to get pregnant or impregnate, you know, their partner. So, so it leads me to believe, common sense tells me that something else is happening, again, assuming that we haven't found anything with the woman. So what about the female? Well, again, this diagnosis of exclusion, we've looked at the fallopian tubes and we've said, no, those seem clear, right? They've done an HSG. We say that the woman's ovulating regularly and that the sperm analysis is normal. So all the tests have been done, and still, you know, possibly up to 10% of women are still unable to get pregnant and unexplained. So what are some of these possible causes? Well, ovarian issues, like I described. Sometimes there's, you know, premature ovarian failure that hasn't been diagnosed. There might be a low egg reserve. You know, oftentimes they're testing basic hormone levels like follicle stimulating hormone. You know, maybe they're doing an antral follicle count. But again, you'll see my checklist later, but when patients come into my clinic, I'm asking all of these questions, and I don't want to just hear from the patient that the blood tests are normal. I want to actually see them, because oftentimes what's normal to them is not normal to me, especially from a functional medicine standpoint. So ovulatory issues, obviously a big issue. Up to 40% of infertility can be due to ovulatory issues. So are the follicles not maturing? Is there some luteal phase defect going on? Do they have low progesterone levels? From a Chinese medicine standpoint, you know, I'll see a lot of issues in the luteal phase, the second half of a woman's cycle. And oftentimes, you know, the way that we can correct that is we work on correcting the first half of the cycle to influence the second half. So sometimes, you know, luteinizing unruptured follicle can be an issue. If there's endometriosis, there can be some chronic inflammation there, which is affecting the follicles in their maturation. So, and then the tubal issues we talked about, blockage. You know, I have to tell you that of the number of HSGs where they shoot the dye through the fallopian tubes to check to make sure that the tubes are open, I have only seen that be a problem like once or twice. So I think it's a good thing to rule out. But oftentimes, you know, unless somebody, you know, has a history of sexually transmitted disease, chlamydia, pelvic inflammatory disease, things like this, I really don't see blocked tubes as the issue. But, you know, I would never say don't get the HSG done. It's a little bit invasive, but I think it is a good thing to rule out. And really you have to if you want to lump somebody into that unexplained infertility category. So some of these things here, I have less explored things, and this is what I find that the doctors are not exploring as much. You know, I have a handful of tricky cases over the years where, you know, their immune system has just been the issue. There was a great doctor in New York who just recently passed away suddenly, and he was sort of a brilliant mind that I would send people to for really tricky immunological issues. So endometrial receptivity is a big issue in the IVF world. They're doing, some clinics are doing more of this, but you know, it's a lining. If the endometrial lining is less than 5 millimeters, usually they won't do a transfer. And you know, again, we've had some research done showing increasing blood flow to that area can help to build the uterine lining. So stress obviously plays a huge role, and sometimes the doctors dismiss this. Sometimes they say, oh, just go to acupuncture, it will help relax you, as if that's insignificant. Well, we know that stress is involved in a lot of chronic disease for many reasons, but just relaxing the nervous system is not insignificant at all, and can help the body to regulate everything, especially inflammation. And then again, I get into detail with environment and lifestyle, and I'm sure you guys are big on that as well. You know, there's PCBs and BPAs and all of these things can affect ovulation or cycle, can increase menstrual cycles, can reduce some fluid in the follicles. So there's a lot that's happening. So getting people on a clean diet, getting the plastics and the toxins and the chlorines out of their diet is huge. So just to briefly again about oxidative stress. So we know, that ovulation, we need this fair amount of oxidative stress for the body to ovulate. And again, just driving this point home that, ovulation and oxidative stress, like oxidative stress is not always bad. And the body needs it for the hormone signaling. It needs it for the development of the oocytes. It needs it for the tubes to function. It needs it for the follicles to grow and go through this whole maturation stage that they grow through. So again, melatonin is pretty darn popular, but melatonin its function is also as an antioxidant. So just think about this. If patients come in and they are taking a lot of melatonin. Melatonin's a hormone, and I never recommend a patient take any kind of hormone unless I tested to know that their hormone levels are really out of whack. So we know that in IVF cycles that, if we keep doing an IVF cycle after IVF cycle after IVF cycle, with this repeated process where we're giving the patient medications to stimulate her ovaries, that it does naturally increase oxidative stress in the body. So this might be a good time in which we make sure that the patient is on, some kind of antioxidant protocol, whether it's diet, supplements, acupuncture. And, we know that too much, bad oxidation can decrease the pregnancy rates. But, as we talked about, are supplements always the answer? With caution, they can be. There are some great, N-acetylcysteine. I use that sometimes when patients have an extreme amount of inflammation, whether it's endometriosis or, failed IVF cycles, because I think something's going on there. We've talked about these environmental factors, the plastics, animal fat. I don't think all animal fat is bad. We'll touch on some nutrition stuff in a little bit, but, too much can affect menstrual cycles. In Chinese medicine, menstrual cycles are the foundation of one's fertility. And so we always work to regulate those first and foremost. Again, I'm telling all of my patients, if you guys are new to practicing fertility, I try to get the patients clean in terms of getting all of the, bleached products out of their home, from toilet paper to tissues to tampons, sanitary pads, just really getting clean with those things. And, obvious levels, lead, cadmium, or, I've tested some patients, or they've come in with some testing, actually testing high for some of these things. So I don't find this as common, but, I do explore lifestyle stuff with patients. Like, I want to know what their job is. So this whole idea of endometriosis, this is called subtle endometriosis and unexplained female infertility. And again, I have a number of cases where patients come in, the doctors say, oh, no, you don't have, endometriosis. And I start working with them. I use a lot of diagnostic tools. One is basal body temperature charting. And I see that they have endometriosis. And there's clear signs usually when I can pick this up in their charts. And I say, I think this is what's going on. But the problem is not everybody gets the surgery, the laparoscopic surgery, to diagnose endometriosis. And that is the only way that you can truly diagnose this. So, I'm just telling my patients, look, advocate for yourself. If you really think that this makes sense, you have a family history of it, or you have all the signs, or you think that there's a really good cause for this, that's, something to definitely explore. And, you know, again, using basal body temperature charting, I can see if someone has low progesterone levels, P4, in the second half of their cycle, even if they have a mild form of endometriosis. So if somebody has those low progesterone levels and they're low enough that you think they might be influencing things, but not low enough for the doctor to be concerned, again, I might suspect this mild form of endometriosis. I have a case last year, girl comes in, we think this is what's going on. She said, you know, I've been trying for 3 years to get pregnant, and the doctors think I'm crazy. They tell me I don't have endometriosis. You know, working with me, that's what we think happens. She decides to convince her doctor to do the surgery. They do the surgery. They find some just stage 1, maybe pushing towards stage 2. They remove it. She conceives, she tries to get pregnant that cycle. She said she was so sore, but she said, you know what, I'm going to try it anyways. And she gets pregnant. So something was happening. Was it the endometriosis? Sure seems like it may have been. So again, with endometriosis, again, it can affect the whole menstrual cycle. Sometimes if you have a patient that has these really long follicular phases, the first half of their cycle after their period, this might be an indication as well that the follicles aren't quite growing well enough. And this can be because there's too much, as we discussed, too much oxidative stress. So I just want to touch on this a little bit. I did a whole presentation last year on telomeres and Yångshëng, which is basically like one's vital essence. And I think it's a really fascinating topic. Telomeres are these little end caps on the ends of your chromosomes. And the theory is basically that the shorter the telomeres get, the shorter your lifespan. So they've done a lot of research on telomere shortening and reproduction. And they basically said, this one scientist, David Keefe, he says, yeah, I think that this is really what's going on in women. He thinks that the telomeres are getting shorter and shorter because there's too much oxidative stress, because, you know, there are toxins in the environment. He also found that, and this is regardless of age, that some of this stuff is happening. And he also found that shorter telomere length was noted in these men that have idiopathic infertility. So these men in which we know that there's some sperm issue happening, but we don't really know why. This could be one of the things that is occurring. So, you know, these DNA segments, free radicals can basically end up damaging these segments. And what happens then, and again, they can become damaged because of lifestyle, stress, poor diet, environmental toxins, and then they end up shortening the telomeres. But we know that certain things can protect against this. Vitamin C can protect against these free radicals. Again, does that mean everybody should go out and take a vitamin C supplement? No, maybe everybody should eat an orange. And again, like we talked about, we know that STL is sperm telomere length. We know that mild oxidative stress is needed in the body for the body to do what it naturally knows how to do. So sometimes we don't want to mess with this. So the point I want you to get out of this particular slide is that, again, this theory of that these oocytes, the eggs, are aging because there's this like lack of blood flow to the reproductive area. But in orange here, we have the oocyte, and they used to think that that the egg was the egg was the egg, and that the egg, you know, couldn't be influenced. But what we now know is that, you know, this is the whole controversy of genetics versus epigenetics, is that the egg is surrounded by these cumulus cells in green. And if we can get more blood flow to the cumulus cells, you know, I use acupuncture, but we can use herbs and supplements, nutrition, massage of some kind, that we can actually influence the the quality of the egg. So genetically, what I'm trying to do oftentimes in my treatments is I'm trying to impact the follicular fluid, which is basically the epigenetic state of that maturing oocyte. In Chinese medicine, we have this concept called Yångshëng, which is like nourish life. And so, when it comes to controlling your rate of aging and preventing aging, we said, oh, there's things that we can do to slow down the rate of the telomeres getting lost. So there's certain things that we can do, like we avoid harm, in which we try to stay away from the excesses. So not too much drinking and not too much, poor diet. But then if we want to actually promote health, where we can at least maintain and prevent the telomeres from getting any shorter, then we say, okay, we're going to eat really good food. We're going to, keep our emotions in check. We're going to sleep 8 hours a night. We're going to have friends and a social life. But the really good Qigong, Buddhist masters, they say to really nourish this life, we need a good mind. We need to limit our food intake. The whole thing now is, you guys, I'm sure, know much more about it than I do, and whether it's good or bad, and I know it's controversial, is the whole idea of getting into a fasting state for a certain period of time. But really, the classic Buddhist monks, that's sort of what this whole idea of nourishing life was about. And they say, look, we should limit our food intake, and we should have this period of no fasting, and we should keep a peaceful mind. And that's really what helps to lengthen our telomeres and, again, nourish our aging, and that includes our reproductive aging. So it's a fascinating science that is developing at lightning speed now. And if you're interested, yeah, go and read about it, because it's really quite interesting. So getting to the meat and bones here of, so how do we look at this in clinical practice? How do we evaluate and integrate some of these treatment principles? Well, I've sort of broken this down into steps. So the medical doctors should be doing some of this stuff. I take it upon myself to ask these questions, because oftentimes I feel like they are coming to me with a diagnosis of unexplained infertility. And as I said, it's really just unexplored. They have not really looked deeply enough. Yeah, maybe they've done one sperm analysis, maybe they've done the HSG, but then they sort of stop. So I have a checklist I use in my office, because the human brain forgets things no matter how many times you've done it before. So I will make sure they've had the sperm analysis. Again, I like to see the results. I question, are there ovulation disorders going on? I'm having patients track their basal body temperatures. Doctors are poo-pooing that, saying, don't do that, it's a waste of time. I think it's extremely useful. Insulin resistance oftentimes is an issue that is, I've seen this number and time and again with recurrent miscarriage. The mechanism is complicated. I'm not sure I understand it completely myself, but one of these immunology guys in New York has found this a number of times with some of my patients. So thyroid issues, extremely common, extremely common. I don't know if you guys see this or know this, but I see this a lot. And I see, OBGYNs and family medicine doctors say, oh, the thyroid, the TSH, first of all, they're just looking at the TSH, which isn't good enough. I see them look at the TSH and they say, oh, well, the TSH is 3.5. Yeah, that's well within the normal range of 4.5. So yeah, that's fine. It's no problem. Well, I've never seen a woman get pregnant with a TSH of 3.5. And if she does, she's probably going to miscarry. So I prefer a full thyroid panel. I like to look at those ranges. And I always ask for that, and I ask for the results. So pituitary issues, sometimes I see this as an issue with ovulation. I have patients that I've tried to work with and regulate elevated prolactin levels, which can be an issue. It's not that often, but again, I do ask for it. If anybody, in terms of having elevated prolactin, common symptom sign to look for is if a woman has any nipple discharge, and or if she has later ovulations. Those are two things that usually clue me in that I want to check those, or at least, if I can't order those labs, see the results. So then I sort of ask myself all that, and then I go, okay, let's go back here. Let's look at this again. Did we look at everything? Does the semen look okay? You know, should we send out and have the semen analysis looked at more closely? Should we look to see if there's any DNA fragmentation? Is the patient ovulating? Is there any, you know, again, in my basal body temperature charts, I can see if patients are having a sluggish time ovulating. In Chinese medicine, sometimes there's heat, there's not enough energy, or there's, you know, some stagnation that's preventing that from happening easily. And yeah, so we'll look at the tube issues as well. But, you know, again, back to the laparoscopic surgery is, you know, some of these docs are saying, look, like the question isn't, you know, if you label somebody as having unexplained infertility and they've been trying to get pregnant for a while, you know, the question isn't, you know, the question is, when should the laparoscopic surgery be performed? It shouldn't be like, do we do it or don't we just exclude it? But, you know, a lot of these docs think, some of the more refined ones think that we should absolutely be looking at this, and that diagnostic evaluation really isn't complete until this has been done. We talked a bit about the endometrium and being too thin, but conception, we know, rarely occurs when it is less than 6 mils. So I have an IVF center I work with, drives me nuts. They insist that if it's over 5, they'll do an IVF transfer because they say in their clinic that it works. And I'm just not convinced, and the research doesn't really support that. So if I have a patient that's going through IVF, I always ask them how their lining is. With acupuncture, I can influence the endometrial lining. So I'll always make sure they get those results and advocate for themselves. You know, cervical mucus, they used to test this by doing this PCT test years ago. They don't do it a lot anymore, but some people think that they should. And they say, you know, this quote here, that the power of this really overrides that of a semen analysis, only except when the sperm numbers are really depleted. So if the sperm count is really low, don't worry about this. But otherwise, like, this could tell us a lot, and they never do this anymore. And again, you and I can't control that, but I'm always advocating for the patients to be their own best advocate. So I do think that this is probably happening, and you know, maybe some, you know, better testing is coming down the line. As I said earlier, that I think a lot of this is because we just don't have the diagnostic prowess yet to be able to look at some of these things. But again, when they do this test, they say, look, we have a higher overall pregnancy rate, even in couples that have this, you know, male factor issue. So perhaps they should be doing this more. So Clomid, clomiphene, and letrozole are pretty common. So, you know, I always ask the question, if a patient, you know, is this the necessary route for them? Well, if a patient has ovulatory issues, then Clomid sometimes is a good choice. In Chinese medicine, we think Clomid is a very heating drug. So if somebody has a thin endometrial lining, this is not the drug that I, you know, really want them to use. So that might not be necessary for them. The other thing that people forget about this particular drug is that, you know, Clomid has been around forever, and they use it because they don't really have any other tools in their toolbox. And again, I'm not saying that I don't like Clomid. I think for some patients, it might be necessary and might help them. But for some patients, it may be hurting them. And the thing with Clomid is that research that was all done with Clomid to say that it can help increase pregnancy rates, that was done with women that weren't ovulating. So if a woman is ovulating, how much is Clomid really helping? I got to tell you, I don't have many patients in my practice that do get pregnant with this. And then the question becomes, you know, should it be combined with an intrauterine insemination, or shouldn't it? So, and then we have the whole IVF. And, yeah, again, you and I can't influence whether the patient does this, but there's certain testing that you could look at to see, and the doctors look at it to say, look, does it help to influence the success of IVF? Just one thing you should be aware of with the terminology here is, we used to call this genetic determination. They make the embryos, then they send them out for genetic testing. It used to be called PGS, pre-genetic screening, and pre-genetic determination. Now they call it PGT. So just be aware of that. If somebody was talking, because somebody got grilled in my field the other day for using the wrong terminology, but you might see that changing. You might see that come across your desk. So I talked about the basal body temperature charting. And, it's funny, I have a lot of doctors poo-poo that, but, if you can get your patients to chart this, and you can really learn a lot about it, you can really understand a lot about what's going on. And, the American Society for Reproductive Medicine, they even say, look, hey, it's cumbersome to do this, and, we don't really recommend it, but it's a great, inexpensive way to see if you're ovulating. And I think, well, they're talking out of both sides of their mouth. So they saying like, yeah, we think it's great, but we don't really want you to use it. And that to me is just, a little bit frustrating, because again, like I said, I'm trying to empower my patients. In China, when I work in the clinic there, what happens is young girls come to us and they bring their basal body temperature charts. They're not, they're 16, 17 years old. They're not trying to get pregnant, but they use it as a way of understanding their body. And, I hope that we get there in this culture, because I think it's an amazing tool. So we're not going to go into this. Maybe I'm sure you guys have seen this. This is the whole process of steroidogenesis. I'd just like to bring this up because this is a really complicated process of pathways. It seems that this whole process and using this diagnostically has become all in vogue in the past few years. But when I first started learning about this, this was a pretty scary process. And again, like I said, the scientists are still trying to understand how this all works. But, the thing that I like to point out is a lot of these pathways can be bidirectional. So we have these major hormones. And if you start supplementing, or a patient starts supplementing with some of these hormones, you might be affecting something upstream or downstream. So, there's certain things like endocrine disrupting chemicals, they're often believed they can have influences on the steroid hormone receptors, and they do influence with the metabolism of these hormones. So again, you guys might be, using some testing in this line. The way I like to explain this sometimes is just, you look at on the left side of this, we have, our stress hormones. On the right side, we have sort of our survival hormones. Years ago, someone said, oh, the left side is, the left side is more about just stress, but the right side is really what we need to survive. We can't make reproduction, without some of these hormones. Yeah, I'm not going to say more than that. This is complicated, but if any of you are using Dutch testing, you might get more into this. But I just, again, wanted to bring this up just to heed some caution. Patients come in, they're taking DHEA, they're taking a cortisol manager. These are affecting other things, and they might be doing more damage. Taking the cortisol manager, for example, these are blockers that can decrease your ACTH production. And it can actually end up lowering your cortisol and increase testosterone. So we might not want that in some patients. So we've talked a little bit about some of these medications that the docs are using, Clomid, for example. Really for unexplained infertility, it's really kind of a contradiction, because if the diagnosis is unexplained, then, and we know that Clomid is really only successful, if there's suboptimal ovulation, well, then shouldn't we have diagnosed them with suboptimal ovulation, not unexplained infertility? And when it comes to, any assisted techniques, like IUI or IVF. So, when the sperm analysis if it's normal, that IUI is really only successful if it's a motility issue. So I see them doing the IUIs all the time for normal sperm parameters, and I don't really think that it's helping. So when is IUI most successful? It's most successful if we know there's some anti-sperm antibodies, if there's some DNA damage, if there's some oxidative stress, if there's something really limiting the sperm, again, mostly motility-wise, that's preventing it from getting to where it needs to go. But, we always have to ask ourselves, the patient does especially, is it, eliminating some of these natural protections as the sperm gets to where it's trying to go to, oftentimes, that's survival of the fittest. So that's not my choice to make, but it's a real subject and it does come up in clinic. So in Western medicine, the immune system from IUI, again, in a lot of these studies, it really doesn't have any advantages for unexplained infertility. IVF, again, there's some poor quality embryos that, if the patient is making poor quality embryos on their own, IVF might be better. They can theoretically make, better embryos. But, again, I think we talked about this a little bit before, is that, doing some of these treatments, especially IUI or ICSI or IVF, ICSI, I'm not sure if everybody knows what that is, but when they actually inject the sperm into the egg, what they found is that the fertilization rates are higher and the cleavage rate, what's the word I'm looking for? The development rate essentially is better as the cells are dividing, but that the miscarriage rate is higher. So are we really doing a good job by using some of these methods? I always ask, is IVF the answer? Well, if you look at some of these stats, the unexplained infertility, not really. Those success rates, are similar, by age group compared to some of these other things. So again, if the patient has unexplained infertility, and again, this isn't our choice, it's their choice if they want to pursue IVF, but oftentimes that's not really a good strategy. So, we know that in a lot of patients that IVF can shorten this time to pregnancy in couples that have unexplained infertility, but I really think that that's really all it adds. Again, it speeds up that process, and, other than that, not so much. There was this trial done by a doctor out of Dartmouth, and this FAST trial, and basically it was a randomized clinical trial, and they really wanted to evaluate optimal treatment for unexplained infertility. What they noticed with this was there was an increased rate of pregnancy, but really the ultimate results of this was that, look, we should fast track those people with unexplained infertility if they're over a certain age. So if they're over 38, that fast tracking them to IVF, not doing 4, 5, 6, intrauterine inseminations before they get to IVF, that they really should increase or I should say shorten the time in trying all these things unnecessarily, because trying them, they're not increasing the success rates. And what they ended up finding, again, like they ended up saving the patients, on average $2,600, something like that, $2,600 or something. So again, I'm counseling my patients with this, that, if the doctors are saying, look, let's just keep doing, IUIs, and sometimes the insurance companies dictate this stuff, but that just might not be, sometimes patients have just had enough. Sometimes they've just had enough. So, again, Clomid, I'm kind of preaching this, but, basically we say, look, like for unexplained infertility, we really don't have any good evidence to say that it has any significant benefit. And they're really, sperm, abnormal semen parameters. Western medicine saying like, look, we really don't have any medical treatment that's proven reliable for this. So that's where people like you and I can come in and really influence them with nutrition and, the right supplements perhaps, and diet and exercise and lifestyle. So for me, it all comes down to, in clinical practice, it comes down to using a checklist. And I think I quoted, this book here. So this surgeon out of Mass General, brilliant guy, has written a number of books, but he wrote this book called The Checklist Manifesto, and I absolutely love it. I'm like to analyze things. And so, basically said, look, like, it doesn't matter how long you've been doing something, and especially if you've been doing something for a really long time, is like having a checklist just helps our memory because we forget things. And we can just really fool ourselves into thinking like we don't need those things, and we end up skipping steps. I mean, why do pilots still use a checklist, right? Because it's a pretty important job. And if you do something over and over again, day in and day out, you might forget things that are pretty important. So I'll share with you part of my checklist, and maybe it'll be helpful for you. So this is part of the checklist, but I sort of just mapped this out, like just so I can see on one page what I want to remember to ask about. I want to know, is the patient ovulating? Have they checked any kind of insulin resistance? Is that an issue? Is their thyroid operating well? If there's ovulatory issues, like are there, what's the sex hormone binding globulin? What's the testosterone levels like? Is there a reason? Do I notice any signs and symptoms that say that the androgens may be elevated? And then I ask the questions. I want to see the semen analysis. Want to make sure the tubes are open. We talked about the endometrium, and I'm questioning along the way, what can I do from a Chinese medicine standpoint? What can I do from supplements, nutrition, lifestyle, and where am I going to have the biggest impact? But more specifically on my checklist, I literally have this on my desk, and I'll look at this, and just reminds me of things that I can ask the patient, because again, oftentimes with unexplained infertility, I'll find other things that are happening. Again, the thyroid, it's huge. Oftentimes, numbers, dozens of times, I've seen patients with a diagnosis of unexplained infertility, and it was really just a thyroid issue. And people don't eat well over here. I don't just ask the men about the veggies, but I do find, I'm stereotyping, that men don't eat as well as their wives, even if the wives are cooking, because when they're at work all day, they're making bad choices. Yeah, I mean, you guys can use this as a reference. I'm not going to read every one here, but there's certain triggers. Asking about erections as well is pretty common. Usually the guys, if I can get them in here, are pretty good at answering that, but that might tell you a lot about what's going on. If they can get an erection but just not sustain it, usually I find that that's more of an emotional block. If they're just having trouble even just getting a full erection, then usually it might tell me that there might be something physiologically going on there. So I don't know if there's any Chinese medicine people on this tonight. I know a few colleagues might be here, so I put this on there, but these are some herbs that I use in Chinese medicine that I think of oftentimes with unexplained infertility. One, because I'm thinking about antioxidants when appropriate. Two, there's a lot of inflammatory issues, especially with conditions like endometriosis. And then I think more adaptogenic herbs. And the mushrooms, Lingzha is a reishi mushroom, that's and chaga mushroom, pretty common these days. Again, I use these when appropriate. And we say in Chinese medicine that reishi mushroom, tonifies the jing, qi, and the shen, which is like the three vital treasures that, one needs to have a balanced, harmonized body. But for unexplained infertility and gut health, ton of research coming out about the microbiome. So much we don't know. I think we've just barely scratched the surface there. But, I'm preaching to the choir now, if you guys are all nutritionists here, about, 5 things I'm usually telling my patients. No wheat, no dairy, no sugar, no alcohol, no caffeine, The reasons for that, really, I'm just trying to reduce the inflammation. And, you know, again, some people can tolerate some of these things better. I never have a one-size-fits-all approach. But, you know, I'm always trying to get more food first into my patients. I'm tailoring this also according to their Chinese medical diagnosis. We look at things a little bit differently. But these are some of the, you know, general things that I might do. This, my little coconut milk smoothie there with chaga. If somebody has leaky gut, sometimes, you know, the chaga is a great mushroom that can help to repair flesh. So I wouldn't use it during an active episode, but, you know, post-treatment, if we're still trying to repair things, that might be something that I would add. And sometimes I'll just, you know, give them either chaga in a Chinese herbal formula, or I will even just sometimes give it separately, even though that's generally we use things in Chinese medicine in formulas. They have a much more synergistic effect when we use herbs combined. And then this last thing is just about tonifying the middle jiao. So, you know, if any of you are familiar with acupuncture, these are some acupuncture points, which again can help to smooth digestion depending on, you know, what's the particular issue. So yeah, I mean, really, like the foods that we're craving, it's not just because we're craving these, it's because our bodies are really trying to adjust themselves. That's the way I look at it. And the microbes in the gut are dictating that. So one of the best things that I love for that, you know, everybody's all hooked up on kombucha and the other kefir there. And I think kombucha can be great, especially if you make it yourself and you can moderate the sugar, but, you know, oftentimes it has a lot of sugar in it. So I think the best thing that, you know, I do, sometimes I'll just, you know, make a dozen little fermented veggies, so easy to make. You guys probably know, but these are some of my favorite recipes that I'll make and give them to different patients. But you know, real easy to make, and you can do it at home, and in a couple of days you have your own fermented veggies. I like to put this in, I put this in there because these are some of my top 11 foods. This doesn't mean that everybody gets all of these foods, but I think some things get a bad rap, right? Like I want to make sure everybody's getting good, healthy fats in their diet. You know, a lot of lean PCOS patients that I treat. And, you know, oftentimes their problem is they're just not getting, if they don't have high androgens, they're not getting enough good, clean fats in their diets. So, you know, everybody thinks red meat's the devil, but I think that, I think for some patients it's really good. I think if it's grass-fed, it's even better. It has, you know, all omega-6s. Maybe you guys disagree. I don't think are bad. I think some omega-6s that you get from grass-fed beef would probably still be good. The seaweeds are discounted. I think those are an amazing source of minerals that a lot of people are lacking. You can do micronutrient testing to see if patients are lacking in this stuff. I love the dark leafy greens. I think that people aren't getting enough of those. I'm, you know, more for veggies than fruits. But, you know, I love the berries because they're loaded in antioxidants and low in sugar. So, and again, I love my fermented vegetables when they're the right fit for a patient. So kind of wrapping up here, winding down is, you know, things to think about. Like a patient comes in, they have a diagnosis of unexplained infertility. Like, what is their existing supplement regimen? What supplements are they on? Sometimes getting them off of some of these things is the first step. I always say to my patients, especially my acupuncture patients, sometimes they say, oh my God, that's all you're doing? You're only doing that many needles? And I say, yeah, I'm only doing that many needles because more isn't better. Better is better. And the same thing applies for supplements. So, you know, protein shakes, I always tell my patients, like, they're not meal replacers. In a pinch, they're fine if it's good quality. In Chinese medicine, we don't love smoothies that much unless they're at room temperature. Sometimes they're too cold for the digestive system, especially for someone that's already cold already. You know, obviously fast food, I don't need to tell you guys that. But Again, one of the things I use in my practice is I do use some of the Dutch testing, if appropriate and possible. It's kind of pricey, but it can tell me some different things, you know, especially if I have a patient we think have some estrogen issues. I can tell how they're metabolizing their estrogen. And again, you know, I'm all for, you know, trying to add their nutrients with food first, based on what I think might be missing from their diets. So these are probably some of the potential supplements that I would consider if somebody has unexplained infertility. We've talked about, you know, a few of these already. And again, not everybody gets the same approach in my clinic, and I would hope that you don't do the same. One size does not fit all, but these are probably some of the things that I would recommend more often if needed. So for PCOS, I am recommending some of the inositols. Again, if somebody does not have, actually that's sort of a typo there, if somebody just has some, if I feel like I just want to impact their ovary health and their egg quality, I might just recommend they take some myo-inositol. If they're PCOS, I might recommend they take, you know, myo and D-chiro-inositol in this 40:1 concentration, and there's some products out there in which they can get that, but it does help to support insulin sensitivity and egg quality. If I think that somebody's unexplained infertility is related more to egg quality issues, right? So I might recommend some CoQ10, specifically ubiquinol, the reduced form, some myo-inositol, and acetylcysteine. I do love this for endometriosis, especially if I think there is, you know, an extreme amount of inflammation. Maca and Vitex, these are on my list here. I am very cautious with these two supplements. Most of the Maca out there on the market is androgenic, and they don't really tell you that. So, you know, you don't want to be raising somebody's androgens, especially if they have PCOS and they already have elevated androgens, for example. So I really hardly ever use this particular herb. And when we think about this, maca was, it was developed, well, it's Peruvian, right? So they started using this, but they used it as real food. And so I think, again, we've gotten a little crazy. We've veered so far off from using real food. And I just love this Hawthorn program. I didn't know about it until I was asked to do this talk, because I think you guys are really trying to teach good quality, you know, nutrition education out there. And really, this is the root of everything. And I think this is what patients need. We don't need a quick fix in a bottle. We just need real food. So, and you know, again, with my vegans, and I don't have many, veganism is not great in Chinese medicine. A little bit of you know, good quality protein, I think, is fine. Not the way the typical American diet eats it, not this big, huge steak on our plate, but sprinkled in more like the way the Japanese might consume protein. But, you know, B12, nutritional yeast, I love these products. Any Chinese medicine people out there, you know, this just might be a sample of how I might treat them with Chinese medicine. So if anybody's interested in that, I won't spend time on it, but if anybody's interested in that, yeah, you can feel free to reach out to me if you want more information there. So wrapping up here, God, I didn't think I'd talk that long, but heck, I did. So here we are. So a couple of points just keep in mind, you know, unexplained infertility is not the same as idiopathic, right? Does it really matter? I think it does, because it might send me down a different path of exploration. Just because somebody has a normal semen analysis does not mean they're going to have a guarantee of getting pregnant. You can have DNA fragmentation. It can still fertilize the egg. But I think that male factor is really, like, if we can get the men into our clinics, I think that's a really huge opportunity for a lot of us. And, you know, oxidative stress can be you know, this intervention site for helping our patients. But, you know, again, we need oxidative stress. You know, we need reactive oxygen species. We need that balance. And sometimes that's hard to assess. But again, we have to look at the big picture, assess the diet, the supplements, the lifestyle, and then make some, determinations, what we can do. But I say, look, question everything. Patient comes in and says, yeah, this is normal, that's normal. Just question everything. Ask to see the reports. My patients are happy to share that with me. And again, the more information we have, the better able we're going to be able to help them. So don't be afraid to use a checklist. And again, my checklist is triggering me like, is there inflammation? Are there problems with the gut, the thyroid, different hormones peaking and falling in certain times of the cycle. So, all right, that's it. Questions, yay.
Yay. Take a breath, take a sip, and we'll frame this a little bit. Thank you so much. What a comprehensive presentation we just got. Yes. So, and I'll say I live by checklist. I would be lost without a checklist, right? And also, thank you for your comments on Hawthorn. And we definitely emphasize biochemical individuality here. It's emphasized, it's practiced at Hawthorn. There's just no one right way for everybody, and we recognize that. And it's always food first, always. Yeah. And the quality definitely matters. So,
yeah, I love that. I always say, look, our bodies are biochemical properties, and food are biochemical properties, right? And so it just still a lot of doctors out there today who just, tell my patients, oh, don't worry about it. You don't have to stop smoking pot. And you don't have to eat well because we're going to do IVF anyways. And that's just me.
Yes, it would make me crazy too. But yes. Oh my goodness. Let's I just want to come back to so many factors play into that to this unexplained and infertility issue. And for myself, I've never been pregnant, so I don't know, and I likely won't get pregnant in my life. But to put it in a little bit of perspective, my younger brother, graduate high school class of 67. And when he got married, they weren't getting pregnant. And everything was all about the woman, it's her problem. We're testing her. And it's like, go get tested, go in, have yourself checked. And it turned out that they were both unable to conceive.
Wow.
And living in a city that is surrounded by big ag and industry. And as agriculture changed to the type that we're, employing now, just tremendous chemical exposure. And they found that when they were going to their class reunions, that it wasn't just them. There was over 50% of students from their graduates, from their class, that could not conceive.
Wow. Yeah.
So, it's a huge factor here of what we're exposed to. And this was back in, 1970,
right.
But they were discovering this. And so it's only really increased from there.
Right. Yeah. It's so common. And this mindset that it's the woman and not the man is just false. And we're seeing it more and more.
Right. And when you talked about the miscarriage rates and the potential for sperm dysfunction and DNA damage, I really appreciated it so much because, it's so much of the blame lies with the women, and the women really take it on. And it's just unexplained, so it's got to be me.
Right.
My husband can get an erection. There's no problem there, but. Yeah. Right. And I really want to emphasize and really appreciate your commentary on supplements and excess and overuse, repeated use can interfere with fertility. And certainly we're talking about oxidative stress as a natural event, and that we need some of it. And certainly we're seeing excess oxidation in tremendous amount of us these days, but using an inordinate amount of antioxidants, you drove that point home really well, and I appreciate it a lot.
Yeah, thank you. I do think, the supplement industry, again, is a multi-billion-dollar industry. So I do think people are spending a lot of money on things that they don't need and sometimes could be hurting them.
Right. And with cannabis, both the cannabis use and the cannabis potential increase now with the legality and so many other people trying it that maybe not have had, and indicating it as an inhibitor of the pituitary is it's we don't hear this. The general public does not hear of the consequences, and so I'm all for medical cannabis and using it judiciously and appropriately. The other piece here follows that. I'm sorry, do you want to say something about the cannabis?
No, go ahead.
I want to get into plastics for a minute, because one of the points you made was we need to get that out of the diet. So our food is packaged in plastics. Hopefully people aren't microwaving their food in plastics, but really and truly it's unavoidable anymore. And I mean, when we're finding it in our table salt and we can't distinguish between the color of the salt and the color of the plastic, it just can't be completely avoided anymore. And so we do our best to raise consciousness, to help people understand the risks and the inherent dangers, and to minimize their exposure to it as much as possible. But we're facing a mounting concern until we get away from plastics all over the place.
The plastic issue is it's crazy too. I was once a week my husband and I, we order takeout on our late night, and the food is all great, and it's this Thai restaurant, and they don't use any MSG, and they try to, the vegetables are all fresh, but then they give it to us. We get the takeout in plastic. And I thought, God, I've got a really good business idea. What you should do is, we should bring our own containers, and you just, you bring a container and you leave it there, and then, every time you go, you get a glass takeout container. Maybe someday we'll get to that, but it's just trying to minimize it as much as possible. You have to make the best choices that you can, but I mean, I hope people get the plastics out of their life, and again, don't be putting those in the microwave.
No, I'm putting all my hope in hemp for that. Anything that can be made, you can make hemp plastic, and it'll biodegrade, and just anyway. So cannabis this and cannabis that. But there's a question that just came in about your thoughts on using CBD, and if you've used that with fertility or heard anybody that is, or any studies.
I don't know anything specific to fertility, but I have a general opinion about CBD. I think CBD is the miracle cure du jour. I think a lot of the CBD out there on the market is not pure, and it's tainted with other things. So unless you have a good quality supplier for that. But I was getting my hair done a few weeks ago, and I could see behind me the hairdresser had a lot of products on her shelf, and I saw CBD, and I thought, oh my goodness. I said, you actually have hair products with CBD? And she said, oh no, that's just my hair supplier. They sell this CBD. It's a miracle product, she said. It's just for, I can't remember, just whatever, like general wellness. And I thought, oh my God, I didn't say anything. I bit my lip, because I thought, I'm sure I don't even have to check the product out, because I'm sure it's not good quality. But, people are just buying it thinking that it's going to cure whatever ails them. And I just don't believe that. There's just not enough research out there. And a lot of the research that's being done, you have to say who's funding that research.
Always, yes. So I agree with all of that. And it's, with CBD, with our food, with our supplements, with our thoughts, with our research, everything, quality matters, and knowing the source. And with this being so new, in the broader general public being exposed to it, its marketing is what they're being educated by. And so I'm happy to be in December. We've got a 2-part very comprehensive presentation on medical cannabis, and so we'll get into it in much more detail, but all of it, the quality and being able to discern what a quality of a product or piece of information is, certainly it's going to matter.
There's only one CBD product I use in my clinic, and it's just a little pain relief cream, but I trust the quality of the CBD. However, There are also two other ingredients, MEM4 and Camphol, that are in this product as well. So I don't know why, patients are using this for some pain-related stuff and they like it, but honestly, I don't know that it has anything to do with the CBD. It could be the unique combination of these three ingredients. I think we just don't know yet. So I'm always cautious until we do know more.
Sure. So you had made a comment about animal fat and as a endocrine system disruptor. And can you expand on that a little bit?
Well, there's been quite a bit of research done in terms of that. And so that usually is really if the animal has eaten inorganic feed or has eaten, a lot of toxins. So basically it's the toxins that we're getting from that fat.
Okay. Yeah. Sure.
Do you guys get into
again,
that?
Yes, certainly. And so I wondered where you're going to go with that. But again, it comes back to quality matters and knowing your source.
Correct. And good quality fats aren't bad, right? So I'm not necessarily saying that, all animal fat is bad, but is that animal fat toxic, essentially? Right.
And then we store it in our fat cells. So
exactly. Yeah. So
question about, there's a lot of controversy with herbs while trying to conceive. Should people avoid certain teas or herbs when trying to conceive? Do you have any main ones that you would mention?
So that's sort of like a big topic. I think one of the sort of Western herbs that everybody thinks of, and oh my God, it's just escaping me now as we're talking about this, is the raspberry tea leaf.
Yes.
And yeah, I mean, first of all, it is known that it can potentially stimulate uterine contractions. So sometimes they're saying that it's good for menstrual cycle quality and health. So the way my mind really works is based on my training. So I don't think that Western herbs are necessarily bad. And I assume the question is more surrounding Western herbs, is that there are, you would have to, good or bad, take a lot of a particular herb to really do something detrimental. But I have had patients come in saying, I'm drinking, 6 cups of raspberry tea leaf a day because I heard it's going to help my menstrual cycles.
Yes. And doing that for months.
And doing it for months, right? So that could be an issue. And then, patients saying, can I drink raspberry tea leaf because it's going to stimulate uterine contractions and I'm 37 weeks pregnant and I just want this baby to come out. Again, I have to say you have to drink a lot of that tea for that to happen. So, some of the mint teas in pregnancy, are considered too, well, in Chinese medicine, we say they're considered too cooling, but those are not necessarily good with pregnancy. The problem with that, a lot of the herbs and teas in particular is there's not a lot of good research out there because nobody's going to participate in that study if you're pregnant.
Right.
So, and in Chinese medicine, again, we use herbs in combination. So a lot of the formulas that I use in my clinic, there might be some Western herb names that people would know, like licorice, white peony, things like this. But we use herbs in combination based on formulas that literally date back to some of these texts 1,500, 2,000 years ago. And so, Chinese herbs in the Chinese medical model can have synergistic effects when they're combined with each other, but they can also have antagonistic effects. So there are tons of herbs like you wouldn't want to take with certain conditions, but that's why, we rarely, I rarely recommend, singular herbs, whether it's a herb or a tea, because I'm trying to treat oftentimes root patterns and not symptoms.
Sure.
Does that answer your question?
Yes, I think so. Yes, the root cause, I mean, it comes back to your melatonin slide. as an antioxidant and a hormone. And you reference, it's like, well, if the hormones are out of whack when it's tested, then, perhaps a supplement. But to me, if the hormones are out of whack, is the supplement the answer, or do we look for the root cause?
Right, exactly.
Why the hormones are out of balance. And so that might lead us to, okay, a short course of melatonin or something, but it's more the root than just the Band-Aid.
Well, right. And I think you just said something really important. You said short course, right? So that implies that we are actually developing a diagnosis for a patient. We're developing a prognosis, and then we're not just sending them away forever and ever and never reevaluating them. And I find that a lot, and that's dangerous.
Right. Yeah, I agree. And then I think lastly here, one more point here was, was another question, but this point first on the Nourish Life slide, the positive result was the Nourish Life slide, and it was kind of the Buddhist approach, peaceful mind, do breathing, limit food intake. And so peace of mind, I've been with the people that I'm working really teaching mindfulness practices, and it's about using our mind, with positive thinking and identifying false beliefs and the negative statements that we repeat over and over again, and training ourselves to reframe that into a positive mindset. And I find it really helpful with myself and with my clients for sure.
Yeah, it's huge. It's huge. We all, I always say, like, and I'm one of the biggest culprits right now, right? I keep telling my husband, like, no, I'm going to slow down. I swear I'm going to slow down. But yeah, we're just a culture of just excess in everything. Yes. And we all need to just take a break and stop doing so much. Like, what really is important? Like, how much do we need to be happy? And really, we don't need a lot. Right. So yeah, it's reevaluating.
Always. And I appreciated that the breathing. We didn't go into the breathing, emphasizing the breathing so much, but it's also a piece that I routinely work with my clients. And because deep breathing is going to drop us into parasympathetic mode, and it stimulates the vagus nerve. It stimulates the vagus nerve, and all of our internal organs are going to be fed from it, actually. So.
Yeah, I mean, if there's one thing that we could, even if we did nothing else every day, but we did 5 minutes of deep, deep abdominal breathing, I think that, people's health would just be immensely restored in so many ways. Right.
There's the microbiome slide, and you had fermented veggies. I can't live without them either. I grew up with my French grandparents, and grandfather had his fermentation cellar, so I'm exposed at a very early age. But the thing that was, the question came up about pressed salad. One of the attendees wanted to know, what is pressed salad?
So pressed salad is an old, I learned about this years ago doing some macrobiotic cooking. And basically, I can dig up the recipe and share it with you guys if I can find it. I think I know where it is. I haven't made it in a long time. But it literally is, you take your salad and whatever ingredients that you're using, and you have it in a big bowl, and you put like another bowl on top of it with a heavy weight, and you press it to basically activate everything, right? Sort of like mastication.
Yeah, sure.
To digest and it's supposed to be better. Yeah. So yeah, it's pretty cool. I think the recipe that this was like, just, I can't remember the grains that we use, and we sprinkled them with sea salt and
sure. Whatever your salad is. Okay, one more question here is, do you recommend any of the take-home tests for fertility, like modern fertility? Are you aware of it?
I do use modern fertility with some of my patients that want like quick results. So I think that those are fine. Yeah, I use them. I don't have a problem with them. Again, the problem I have is if patients are doing that and then they don't really know how to,
yes,
they can order them.
Nothing else. Yeah, no other evaluation in that either. That's the only thing they do.
You know, with some of the Dutch testing, you know, I will say that, you know, with basic hormone panel testing, that's good. I mean, I want to see what, you know, the basic, you know, for women, I want to know what their FSH, their LH, their estradiol,
right,
prolactin, TSH, you know, the androgen, testosterone. But, you know, that doesn't tell me about the metabolites. It doesn't tell me any more details. So I do think, you know, again, what we talked about earlier, that the Dutch testing, I think, is good if it's used appropriately by an informed practitioner.
Yeah, and thank you for the emphasis on full panel thyroid. Yes, I go to an integrative doc who is like, will only order TSH, but she'll order anything I want. And so I always get the full panel. She said, I'll order you the full panel, but I want you to know I'm only going to look and go by TSH. And I said, fine, doc, but I've got the rest of the information. I'm participating in my personal choices as well. So it's like, yes, you have to be your own advocate and know enough to be strong about it and take matters in your hands sometimes and help them learn too.
Yeah,
all right.
absolutely.
I think that's enough for today on this topic. As you said when we started, we could go up for hours on it and get into much more detail. And for now, this is a really good start. I want to let everybody know that we recorded this and it'll be available on Hawthorn's website under archived webinars in just a few days. So I'm sure there's a number of slides that I'm going to go back and look at again. You might as well, and spread the word that this presentation has been done and will be posted and is a valuable one to take a look at. There's also going to be a little survey to fill out after the webinar ends. It always helps us to have your feedback and any comments about this presentation. I sure appreciate you taking the time. You want to let you know about our next webinar. It's on August 20th when we host Dr. Deanna Minnick again. She's an expert in and will be presenting on understanding fatty acids from food to labs. That's a good one not to miss. And tomorrow is our next All About Alumni, where I'll be interviewing our Master of Science in Holistic Nutrition graduate, Angela Montoya. So she'll be talking about her post-grad activities, accomplishments, and challenges. You know, we've had so many previous fantastic graduate interview presentations. So I'm encouraging you to check our archives out on that as well. And just lastly, you know, I hope we've inspired you to learn more about health and nutrition with this webinar and all the ones we've offered over the years, and remind you that Hawthorn has a variety of nourishing programs and courses. So visit our website for more details. And if you want more personalized attention, Lizette Picasso is our admissions advisor. And it's a good time to check out our website because with Hawthorn, celebrating national accreditation from the Distance Education Accrediting Commission, we are offering a 20% tuition discount on our Doctor of Science program if you enroll and begin before October 31st. That's over a $6,000 savings. And on all of our master's programs, you can take advantage of a 20% discount on that. So check us out. There's lots to learn and to explore all kinds of things on our website. So I think that's, I think it's time to conclude today's presentation. I want to thank you again, Dr. Katherine, for everything that you've done and for everybody else for sharing this educational experience together. I want to thank James Bernardinelli for engineering our webinars and always keeping things flowing. I couldn't do it without you. Well, I could do it, but it would be a lot more challenging and much less fun. So thank you for that, James. And to all of you, I wish you all the best of health, and I sure look forward to learning more together at Hawthorn's webinars and All About Alumni series, and certainly in the classroom. So take good care, everybody, and we'll see you back here in a couple of weeks.